Welcome to ASA Central Line, the official podcast series of the American Society of Anesthesiologists, edited by Dr. Adam Stryker.
Welcome to Central Line. I'm Dr. Zach Deutch, your host for today's episode. Today I'm joined by Dr. Dan Sessler, who's contributed an article to the May ASA Monitor, which explores the issue of 30-day mortality after anesthesia and surgery. This is a hugely important topic for clinical and regulatory purposes, and I'm looking forward to hearing more about this. So welcome everyone and thank you for tuning in. Before we get into the substance of this issue, Dan, can you tell our listeners a little bit about yourself and give a brief biographical sketch, please?
With pleasure. I have the honor of leading the Outcomes Research Consortium, which at 230 members is the world's largest anesthesia research group. Our goal is simply to do as much clinical research as we can. And in that respect, we're fairly successful. The consortium has published more than 2,000 full papers, and we knock out a new one every other day. I'm board certified in pediatrics and in anesthesia. Initially, I did pediatric anesthesia, then I switched to adult anesthesia. But mostly, I've been a clinical researcher my whole life. That's my focus, and it continues to be where I focus my efforts.
So you're well poised, obviously, to discuss this issue. Let's get into the substance of that now. How common is death within 30 days after surgery?
Death after surgery is remarkably common, and I need to contrast it with intraoperative death. Intraoperative mortality is now so rare that it's hard to quantify. It's something on the order of 1 in 100,000 cases. That's less than one preventable anesthetic death per career. It's really, really low. In marked contrast, between 1 and 2% of surgical inpatients die within 30 days after surgery. Put this in perspective, it's the third leading cause of death, period, in the entire world. Many people die 30 days after surgery. And let me give you an anecdote about this. Grandma comes to the hospital. She has major surgery and arrives stable in the recovery room. Almost everyone assumes that grandma has survived the most dangerous part of her perioperative experience. And that's just absolutely untrue. Grandma's chances of dying in the next 30 days are 140 times higher than they were in the operating room. It's postoperative mortality that we need to focus on because that's where people die. There's just no margin at this point in preventing intraoperative mortality. Literally, it's so low we can hardly quantify it. Postoperatively, lots of patients die, and we have an opportunity to prevent those deaths.
So basically what you're saying is what people have been indicating before is we've kind of made this thing too easy intraoperatively, which is why people tend to take us for granted, but they're really missing the real focus of where there's some gains to be made in terms of public health, which would be the postoperative mortality arena, correct?
That is exactly right. Once you recognize that the 30 days after surgery is the world's third leading cause of death, it's obvious that that's where we need to focus. And we as anesthesiologists have much to contribute. We can reduce that mortality.
Okay, so let's talk then about some specifics. What are the major causes of that? And what factors can you think of or have you identified in your research that contribute to preventable aspects of postoperative mortality?
Okay, let's start with causes of postoperative mortality. The two major causes are bleeding and cardiovascular complications. Sepsis is a distant third, and respiratory deaths are even less common than that, but they deserve special attention because they're nearly all preventable.
Okay. Could you describe either generally or via actual vignettes, what way would those be preventable? What type of clinical scenarios are you referring to?
Myocardial injury after non-cardiac surgery is a major cause of cardiovascular complications. Myocardial injury is defined as a troponin elevation apparently due to myocardial ischemia. It does not require symptoms or signs. So patients don't have to have shortness of breath or chest pain. And in fact, more than 90% of them do not have these symptoms. And you might say, oh, it's asymptomatic. It's just a troponitis. Doesn't really matter. And even cardiologists take that perspective. But that's really the wrong approach because the mortality for myocardial injury that's asymptomatic is nearly as high as it is for a full myocardial infarction. So just because these events are silent doesn't mean that they're unimportant. In fact, they kill people just about at the same rate as a full myocardial infarction.
And possibly we could see how that would progress in that it would tend to be treated more cavalierly and dismissed. It's not the standard profusely sweating patient with crushing chest pain, correct?
It is not yet the standard of care for postoperative patients to have troponin screening, but it should be. 4 different national societies, including the American Heart Association, all now recommend troponin screening in moderate to high-risk patients. And the reason they recommend it is that these events are asymptomatic. If you don't measure troponin, you'll miss 90% of them. And the 90% that you miss are not less serious than the ones you identify. They have just about the same mortality. And you need to know about these events because there are lots of things you can and should do about them. Somebody has myocardial injury. Well, somebody should have a conversation with the patient and explain that they've had a myocardial infarction, which is what it is. It's called myocardial injury after non-cardiac surgery. It's a type of infarction. It's a type 2 myocardial infarction. And by the way, type 2 myocardial infarctions are more deadly than type 1 infarctions. So somebody needs to tell the patient that they've had an infarction and that their chances of having a reinfarction in the coming years is high, and that there are things they can do to prevent that, or at least to reduce the risk, such as smoking cessation, healthful eating, and exercise. Most of these patients should be put on aspirin. They should be considered for statins and ACE inhibitors. And if their blood pressure and heart rate isn't under control, this would be a really good time to get it under control.
So clearly, this is an emerging change in the way we think about things in the perioperative period and how we think about heart health as it relates to risk modification and outcomes. So very interesting point there. But I would like also to touch on the pulmonary system, because you did mention that though the respiratory events, though not as common, are almost universally preventable. Can you give a little bit more detail on that?
Yes. So respiratory deaths are not terribly common in hospitals, but they nearly all are preventable. So they're really tragic when they happen. What causes these events is not exactly nailed down, but my impression is that opioids are a huge player here, way more than obstructive sleep apnea. Worries about patients with obstructive sleep apnea are perfectly appropriate, but I don't think that's actually what causes most respiratory arrest. As far as I can tell, it's opioids. And that means that this is preventable. It's preventable because we can give less opioid. It's preventable because we can monitor patients, and it's preventable because we can treat opioid-induced respiratory depression.
So having kind of dived into those specifics a little bit, let's step back for a second, talk a little bit more in the epidemiologic sense or the more global sense. So 30-day mortality measure, why is that important really? And why is it really important to us as anesthesiologists? And assuming that it is important, what role might we have using our particular expertise to help mitigate or even solve this problem?
30 days is somewhat arbitrary number that people pulled out of the air, but it's commonly used for outcome measures. But let me point out that 1/3 of the deaths within 30 days after surgery occurred during the initial hospitalization. That is, under our care in our highest level healthcare facilities. These are not people who go home and get hit by a bus. And many of the others are patients who were readmitted for some reason. So this is very much a consequence of surgery. The chances of dying in the month after surgery are way higher than dying in a otherwise comparable month, even after careful risk adjustment. So there's something about surgery that promotes mortality. And some of it's obviously a consequence of surgery, such as bleeding complications. But much of this results from aggravation of poorly controlled medical conditions that people come to us with. And then it gets aggravated by surgery because surgery, of course, is an enormous stress, and it produces an enormous amount of inflammation, which sort of makes everything worse.
Okay, that makes sense. And this concept of the inflammatory response being a negative modulator of outcome isn't really a new thing, but the specifics that you're adding in here are all kind of new and concerning. So It'd be nice to pivot from this into kind of some potential solutions and things that we could do as a specialty to make this better. First, we need to take a quick patient safety break. Stay with us. We'll be right back.
Hi, this is Dr. Jonathan Cohn with the ASA Patient Safety Editorial Board. Amy Edmondson's best-selling book, The Fearless Organization, revealed something surprising about psychological safety in healthcare settings. Better teams report more errors. Higher functioning teams don't actually make more errors, but they have a climate of openness that allows them to be reported more easily. Different from a safe space, free of differing opinions, a culture of psychological safety encourages members to ask questions, speak up when things seem amiss, and admit mistakes. As leaders on the perioperative care team, anesthesiologists can help foster this climate by doing things like admitting their own fallibility, asking for team members' opinions, and responding productively when they voice a concern, ask a question, or admit an error. People will make errors, but when team members feel comfortable speaking up, we can prevent those errors from harming our patients.
For more patient safety content, visit asahq.org/patient safety.
Okay, we're back. Let's talk about some things that might mitigate or even solve problems. One of the things that people have talked about, and it's been talked about by industry and also by scholars within our profession, is intermittent vital sign monitoring. What roles could better monitoring play in this clinical picture?
There are two major factors that contribute to postoperative mortality. One of them is insufficient monitoring, and the second is insufficient medical management. So let me start with monitoring. We monitor postoperative surgical patients on surgical wards about the way hospitalized patients were monitored a half century ago. But a half century ago, patients were admitted 2 days before surgery. They stayed for 2 weeks after surgery. We didn't operate on anybody over 60. We didn't operate on patients who had major comorbidities, and we didn't even do really big operations. So a half century ago, the average acuity in a hospital wasn't much different from the acuity at a church picnic. But that sure isn't the way it is anymore. Right now, more than half of our patients go home on the day of surgery. We operate on anybody, no matter what their comorbidities are. Half of our patients are over 60, and we do really big operations. And then we leave these patients sitting on surgical wards. A couple of decades ago, many of these patients would have been in an ICU, but now they're sitting on surgical wards and they get vital signs every 4 to 6 hours. We know that this is insufficient. We know that because when you do sort of autopsies of critical events, either that result in death or near death, and you go back and you look, the vital signs are abnormal for hours in advance. So these things don't just come out of the blue. People don't go from being relatively healthy and stable on a surgical ward to being dead in bed in 5 minutes. They deteriorate over hours. And if we were monitoring vital signs constantly, we would see that deterioration. And we know that with every 4-hour vital signs, many deteriorations are missed completely. So we know that patients have prolonged periods of desaturation. It is not picked up by the nurses. They have prolonged periods of hypotension. That's not picked up by the nurses. Both of these abnormalities are common, profound, and prolonged, and the nurses miss between 50 and 90% of these events. And let me make it clear that this is not because the nurses are failing. We've actually quantified when these events happen, and they happen between the nursing assessments. It's not the nurse's fault. This is a system problem. And until we change the system, we're simply going to miss these vital sign abnormalities that tell us a patient is getting into trouble and would give us the opportunity to intervene. So vital signs is the first thing we need to fix. And this is completely fixable. There are FDA-cleared devices that are battery-powered, don't tether patients, wearable, well-tolerated by patients, that continuously measure all vital signs. Now, a problem with this is that you have a continuous stream of very messy data. And it's not really fair to take, say, 10 streams of data, continuous data from surgical patients, and just feed it to the nurses. They're not trained to deal with this. And besides, they have full-time nursing responsibilities. So we have to come up with some better system. And probably that involves using artificial intelligence and smart systems to identify patients who are getting into trouble, perhaps very early and perhaps in a subtle way, long before any one vital sign passes a threshold. An AI system could look at the pattern and say, this patient is not recovering the way they should. This patient's going downhill, not uphill, and alert somebody. And then somebody, perhaps in a bunker, looking at many screens, ideally an anesthesiologist, looks at the vital sign records, the AI interpretation, and of course has full access to the record, knows when surgery happened, when the patient got their last dose of opioids, can interpret everything, and then make a call to the ward. Hey, Joe, check bed 4 now. That's the way we can save lives with monitoring. Let me now talk about medical management. I mentioned previously that one of the main things that kills people after surgery is not the anesthesia, it's not the surgery per se, it's that surgery and the inflammatory response and the stress to surgery aggravate underlying medical conditions. And most of our patients now have lots of underlying medical conditions, and very often they're poorly controlled. So we bring people who are just sort of barely hanging on with their medical conditions into the hospital. We do a major operation that aggravates their baseline medical condition, and they end up with myocardial injury, acute kidney injury, liver injury, sepsis, all sorts of nasty things that then goes on and kills some of them. Medical management is lacking in hospitals. So surgical patients get perhaps 10 minutes of surgical management early in the morning before surgeons disappear into the operating room. And some patients get a pain consult from an anesthesiologist. But most patients don't get management of their underlying medical conditions. And their underlying medical conditions is actually more serious than their surgery or their anesthesia. And I think that's what's killing them. So the second thing that's missing, in addition to continuous vital signs, is somebody to interpret the vital signs in context with the patient's medical condition and to optimize their medical condition. And I think if we do both of those, we have the potential to save an enormous number of lives. I mean, even if we could save 10% of the deaths, we're talking about tens of thousands of patients per year just in the United States. We can make a huge difference here. The alternative to adopting continuous monitoring and taking an active role in medical management of patients is for anesthesiologists to declare their responsibility ending when patients leave the recovery room. That is exactly the same as declaring anesthesia as irrelevant to the major perioperative problem. That is not a wise thing for our specialty to do.
Just to elaborate, you said quite a bit there, and I think a lot of it was very illuminating. You made a very strong case, especially for talking about the monitoring and ways of trying to interpret it that makes sense. My follow-up question is really about the medical management, and you kind of just touched on it in your last statement there, but how do you envision the proper medical management of patients going forward that isn't, the quick rounds with the surgeon and the every 4-hour checks with the nursing staff? How would you see that happening, whether it involved hospitalists, anesthesiologists, critical care physicians, or whatever mixture of personnel? What construct do you see that would be most effective?
Somebody needs to take responsibility for this. And it doesn't have to be anesthesiologists. Hospitalists are already moving into this space. Internal medicine folks are already moving in. There are already fellowships in postoperative care in internal medicine departments. We should own this field, but we don't have to. If we don't take it, other fields will take it. But I think we're perfectly positioned to take it because nobody is better suited than we are for interpreting continuous physiologic data, including all the artifact that comes with that, understanding what it means, recognizing subtle deterioration, and intervening before patients have a catastrophe. That's our core expertise. Now, I fully recognize the challenge. There's a national shortage of anesthesiologists, although I don't think this is going to last as long as people imagine. But currently there is. And so nobody wants to divert anesthesiologists from the operating room into ward management. But I still think it's the right thing for the specialty to do. And what it will involve is having anesthesia attendings spend time on wards that is assigned there for entire days or days on end, getting to know the patients, seeing the patients several times a day, essentially making rounds with them, treating it like a step-down ICU, because so many of the postoperative patients are sick enough to be in a step-down ICU. They should be getting a higher level of care than we're currently giving them. We are perfectly positioned to do that. It's a field we should own. We should have residents do serious rotations in that. We should do the research that defines the value that comes with postoperative care to actually demonstrate that it saves lives. And finally, we should have sub-board certification so that we can own this field.
So tying into that, a lot of what we do is risk modeling and risk stratification in terms of determining whether in the perioperative period, the patients are appropriate for the surgery or planned procedure. And that's obviously a huge part of any type of medical decision-making. Can you tie that in or talk about how risk models can be used to address the problem of postoperative mortality?
Indeed. There are many models now for predicting risk in surgical patients and in many other contexts in medicine. My favorite is one that I've been involved in from inception, now more than a decade. It's a model developed by the Health Data Analytics Institute in Boston. It's highly, highly predictive. To give you an example, if you use their models and you identify just the 5% of patients with the highest risk, 20% of all major complications will occur in those 5% of patients. And if you take the top 20% of patients sorted by risk, more than half of all serious complications and deaths will occur in those patients. So you can use risk models to identify which patients will most benefit from intense postoperative management. In the spirit of full disclosure, I was a minor co-founder of the Health Data Analytics Institute. I'm a shareholder in the company, and I'm a consultant for them.
Okay, so this sounds like another application for artificial intelligence and software that's specifically designed to get a certain type of outcome. Is that correct?
Yes, it's both deterministic and guided by artificial intelligence. And it also identifies the trajectory of a patient over time, and it updates in real time. And that's where the artificial intelligence part of this comes in, helping to update it in real time. So it's a combination of modeling methods, but the result is a model that's highly, highly predictive. And it's predictive for not only death, but about 200 other things. So you can say, I'm interested in acute kidney injury, and there's a model specific for acute kidney injury.
Okay, so we've touched on quite a bit here, and you've definitely introduced some food for thought in terms of how we approach things like myocardial injury, how we staff our hospital itself, and how we, prepare patients or assess patients prior to their episode of care. So there's a lot of overtly suggested and implied changes that kind of came out of what you've presented. What are the barriers that you see to making these type of changes in our system?
The most obvious barrier is personnel. As I said, there's a national shortage of anesthesiologists. Nobody wants to take anesthesiologists out of the operating room or non-operating room anesthesia and divert them into the ward. We are better qualified than anybody else to do postoperative management and to reduce postoperative mortality. If we don't take it, though, somebody else will. But I really hope that we do, because it's important for the future of our specialty. We don't want to be just operating room technicians. And I'm sorry to put it that way, but that's what is at risk of happening here. If we don't take a broader view, and if we're not willing to recognize that it's not the intraoperative period that's killing patients, and therefore we have responsibilities postoperatively, and we have opportunities postoperatively to reduce mortality. This is something that we as a specialty need to recognize and need to take on.
Okay, so that being said, Do you yourself feel optimistic about solving this problem? What is your overall view of it in terms of where the next few years lie in terms of our specialty and really perioperative medicine in general?
I have mixed feelings about it. I am worried that we as a specialty will miss this opportunity. I'm optimistic that people will recognize that this is essentially a fourth branch of anesthesia. So in addition to pain medicine, critical care, operating room anesthesia, postoperative care should be a specialty of anesthesia. It should be subboard specialized. We should have people who focus in this area. And if we can save an enormous number of lives. And it's an opportunity for us to have a glorious legacy like previous generations. Previous generations of anesthesiologists have a well-deserved, glorious reputation for solving intraoperative mortality. No other specialty has remotely reduced mortality the way anesthesia has. And we all should be proud of this. It's a wonderful accomplishment for our specialty. But that was 20 years ago. What have we done since? The major problem in perioperative medicine is postoperative mortality. If we define anesthesia responsibility as ending at the PACU, that's exactly the same as defining us as being irrelevant to the major perioperative problem. I hope we don't do that.
Your answer made me think of something else. You're really talking about, a fundamental paradigm shift, not only in the way we view our role clinically, but in what duties we have and how we approach our jobs. So a lot of this has to do with training future generations. I'm just curious if you or anyone of your same mindset have had these discussions with educational leaders, among our specialty, ACGME level, lower, I really don't know. I'm just curious if those discussions have been had about the curriculum should be changed in this way, or we should be looking at these type of things to, for the future of our specialty. If you could comment on that, that'd be great.
I've been talking to anyone who would listen for the last decade, but I haven't made specific overtures to educational folks.
Understood. So maybe that's an area of future endeavor, especially if you're very active with the research part of this. It really ties into people's scholarly and academic aims, which are usually developed within training programs.
Mm-hmm. Yes.
So we're coming to the end here, and I want to give you just a last minute to speak to our listeners and to readers of the Monitor. Any final words you want to leave them with, or most important points that they should come away from this podcast and any articles that they might read that are relevant?
Yes. Folks, we have an opportunity here to develop a fourth branch of anesthesia, a branch of anesthesia that can save tens of thousands of lives per year, a branch of anesthesia that can give our generation the legacy that previous generations of anesthesiologists have. We have an opportunity. Carpe diem. Seize the day. Today.
And with that, I want to thank you so much, Dr. Dan Sessler, for joining us. It's been a very interesting conversation. Listeners, thank you for tuning in as well. We hope to see you on the next episode of the Central Line podcast. And for more on the topic of morbidity, mortality, and risk modification, refer to asamonitor.org. Take care.
Stay ahead of the latest practice and quality advice with ASA anesthesia standards and guidelines, freely available to keep you up to date. Browse now at asahq.org/standards-and-guidelines. Subscribe to Central Line today wherever you get your podcasts, or visit asahq.org/podcasts for more.